So I'm presenting osteonecrosis of the femoral head. I chose this topic. It was quite an interesting topic that I saw a few times in my exam. We had a eyesore on this topic as well as a young patient that I examined with decreased range of motion in the clinical station. So I thought it's always a relevant diagnosis to think about in a young person. So we're going through from background all the way to different treatment options. It primarily affects weight-bearing joints, hips, knees. It can affect the upper limb, but less commonly. It occurs generally in the younger subset of patients and has a predominance for the male population with a 4-to-1 ratio. It's commonly bilateral, or the symptoms tend to be staged, so it's certainly something that should be kept in mind when the patient presents with symptoms from one hip, and looking at the amount of prevalence in the US in terms of total hip arthroplasty as an endpoint. It's about 10% of all arthroplasty in the US. The etiology, the end result of avascular necrosis, is the death of the bone cells itself within the femoral head. Think of etiology in this instance as both as risk factors as well as the actual pathogenesis of avascular necrosis. So there are multiple risk factors that have been identified, either direct or indirect, although their mechanism is unclear. So the pathogenesis is actually still unclear. It's thought to be multifactorial, and I think can be broken up into thoughts of it being either ischemic, direct cellular toxicity, or there's an altered differentiation of the mesenchymal stem cells itself. Risk factors, this is a question they like to ask, and maybe for the guys, for the registrars, will certainly ask this during the training quite often, and your history should be based around this if you're seeing a patient who may present with avascular necrosis. And the most common causes are that at the top of both of the direct and indirect risk factors. That firstly of trauma, so be either a fracture with greater amounts of displacement having higher rates of avascular necrosis, as well as hip dislocation. Corticosteroid use and alcohol use and idiopathic make up the far majority of risk factors for avascular necrosis, and then the list is never ending in terms of other potential causes, including Caisson's disease, Gaucher's disease, and blood dyscrasias such as thalassemia and things that make blood thicker, basically, so coagulation deficiencies. The pathogenesis, as described earlier, I think there's 3 different mechanisms. Ischemia is the most obvious, and it's either a vascular disruption from trauma, which is fractural dislocation, vascular compression or increased pressure within the femoral head itself, which is the thought process behind corticosteroids and alcohol increasing fatty infiltration into the femoral head, which then causes constrictions of the vascular supply to the femoral head. Intravascular occlusion also is a pathogenesis with protein C and protein S deficiency patients, thrombophilics, as well as factor V latent deficiency. Direct cellular toxicity is also the mechanism of steroids, drug-induced, and alcohol, as well as post-radiation or irradiation. Altered differentiation of mesenchymal cell cells is the third etiological pathway that's been proposed. Clinical presentation can be mixed. The patients that I've seen throughout my training have certainly come in the later stages of avascular necrosis, with often been misdiagnosed or had normal radiological parameters. So there should be a high index of suspicion, especially if the patient presents with multiple risk factors. And this is important because an earlier diagnosis allows earlier effective treatment, which should improve the outcome. And I'll go through the natural history of what happens in avascular necrosis. But patients often present with pain. This is should be within the groin or lateral thigh region, hip irritability, and finally a loss of range of motion, especially rotation and internal rotation and flexion is the range of motion they tend to lose earliest. The radiological markers of avascular necrosis follow very carefully to the staging system, which was described in the 70s. And so in the earlier stages, the x-rays can be completely normal, including sclerosis and cysts, then having subchondral collapse, which is the hallmark crescent sign, then with flattening and changes within the femoral head morphology, And then the late sequelae then is osteoarthritis affecting the whole hip joint. MRI really now is the benchmark for avascular necrosis, especially with its increasing availability. Lieberman showed in his study in 2003 in CORE that it's very sensitive and specific. And there are two hallmark features. This is a T1 weighted film, which shows a single line density, which is the interface between the necrotic bone superiorly and the viable bone, which is inferior. And the hallmark they talk about really is the T2 sequences, where you see a double line density, which delineates your hypervascular granulation tissue and then the necrotic bone interface, so you get two separate lines. This is a question on one of our exams, actually, as a multiple choice question from a recent JOS article. The other important differential that this can help with is with transient osteoporosis of the hip, which tends to affect females in the third trimester of pregnancy, and it affects the entire proximal femur and is not just isolated to the femoral head itself. So you'll see marrow reaction throughout the proximal femur, and this is a self-limiting condition that will get better, so it's an important differential to consider. There are numerous classification systems, and I think a lot of them are quite complicated and are used for research tools. But the ideal one is one that's obviously practical, it's validated, it's very reproducible, and it also helps with research, but also to prognostically guide us in our treatment. For the exam, and what I think you need to know are these basic ones, which is the FECAT and the modified FECAT, which I think is more relevant. Be aware of the Steinberg classification, which is also the University of Pennsylvania classification, which is more a research tool. And the Kerbal necrotic angle, which is something that I hadn't heard of until studying for this exam, and one that I don't think most people use day to day when they see patients with avascular necrosis. So this is a French surgeon out of Toulouse, FECAT, who was a professor involved in World War II and did a lot of work during World War II in France. And his name, along with Arlett, is against the Sentinel papers on avascular necrosis. He's got two papers, so he originally described in 1960 and then in 1985 in JBJS with a modified FECAT, which is what most people use now. His initial staging system, which I'll go through, was purely radiological with X-ray markers, and subsequent to that, his modifications have included now a stage 0, which is preclinical and pre-radiological, as well as more invasive testing. So looking at his modified classification in the 80s, he also looked at symptoms, what bone scan findings, as well as a functional exploration of bone, which is where core decompression really arose, where he realized on looking at these things of pressure, of biopsy, and of venography, that patients were actually getting better with decompressions. This is quite a complicated looking slide, but to break it up, I think the staging system is important to delineate whether someone's pre-collapse or has had collapse. And so this helps in thinking about it as either being early transitional, where you have a crescent sign, and subsequently with late, which is a patient that then presents with collapse. He goes through radiological markers with an X-ray and bone scan, as well as the hemodynamics on the biopsy itself. I thought of this for the exam as the most relevant thing was that a stage 0 is preclinical and pre-radiological. Stage 1, as described here, has a normal radiographic appearance where the patient is symptomatic. Stage 1. Stage 2 is a transitional phase with sclerosis or cysts within the head. Stage 3 is subchondral collapse, and you get a crescent sign, and then grade 4 obviously is then affecting the acetabular side. So this is a summary of that accepted modified FECAT, which we used as a group for this exam. Yeah. They're all at risk, exactly. Histological. That's true. As mentioned, the Steinberg classification, which is out of Pennsylvania, I think it's more of a research tool. It's essentially the same as the fecat but it's the first one to include the MRI. And it importantly measures the size of the lesion as the first parameter. So this doesn't project very well, but each stage is divided up into the amount of the femoral head that's involved, A, B, and C. And C being severe, which is more than 30%. And then you go through the stages, which are essentially the same as the fecat all the way from a normal radiological scan to advanced degenerative change. But I think this is more of a research tool than clinical practice. The Kerbal necrotic angle. So this is an angle that's measured on radiographs, an AP and a frog leg lateral X-ray with high inter-observer problems because of the fact that it's difficult to accurately work out where the avascular necrosis is on plain films, but it's an addition of both angles. And that was described by Kerbal in the 70s. It's been subsequently modified and is now used quite commonly on MRI, where mid-sagittal and mid-coronal scans are chosen and an addition of angles is used. This is important because the size of the lesion has implications for its management. And the cutoff really is that if you have a necrotic segment that involves more than 200 degrees, you have very poor results with bone-preserving procedures, whereas a smaller lesion tends to do better. So in terms of treatment, we'll talk about the factors to consider, what the natural history is and how to change natural history, and then options, be it non-operative, and then finally surgical related options. So I think factors to consider, you can always think about this in regard to patient factors and then the lesion itself, is firstly, what is the patient's age, whether the etiology is irreversible or there is an offending agent such as corticosteroids or alcohol that can be addressed, and whether the patient has any symptoms. The lesion itself, using radiological markers in terms of whether there's collapse or pre-collapse, the size of the lesion, where exactly the lesion is, and whether there's corresponding acetabular involvement. The natural history, there's quite a few studies out there looking at natural history, which I thought was quite uncommon for most orthopedic conditions, that we commonly think we know the natural history, but there isn't evidence out there for the natural history. But overall, I think most of us think that symptomatic femoral head osteonecrosis will get worse in time. And the progressive nature of this, and in terms of factors important, are the extent of the lesion, where the lesion is, and very importantly, whether there's bone marrow edema in the proximal femur, which is highly prognostic, or whether it will progress. This sentinel paper from Michael Molt in Maryland looks at the natural history of untreated osteonecrosis of the femoral head, and this was in asymptomatic individuals. It was a systematic review of 664 hips, and almost 60% progressed to symptoms or collapse. Smaller lesions and medial lesions had the best prognosis, which makes sense. And in terms of etiological agents, the sickle cell anemic patients had the worst prognosis, and in there's a study out of Greece in 2005 which looked at 70 patients with sickle cell anemia, and 80% of them went on to progression within 36 months. SLE had the most benign course. In terms of management options, non-operative management in regard to observation or protected weight bearing has very limited evidence. And it's not something that I've seen used when these patients have been seen in clinic. And the various drug treatment options, which I'll go through, are really complicated by the fact that we're not still clear about the pathogenesis and the etiology of this condition, and the fact that it is multifactorial. One thing I read a lot about was the thought that steroids were incredibly important in the progression and in the etiology of avascular necrosis, yet there are a lot of studies out there with patients that have received very high doses of corticosteroids for organ transplant who haven't developed avascular necrosis with very limited numbers. I think it's multifactorial. Medical options, there are multiple in the literature, and multiple that have been used, and there is evidence for and against each of these, although the numbers are very small, so I think there's very limited evidence. There's certainly no level 1 evidence. Most described is bisphosphonate use for this condition. And this is, just to remind everyone, it's from an osteoclastic inhibition, which then increases your bone mineral density and then delays collapse of the femoral head. There's a lot of evidence in animal models, but its evidence in the human population is not there, and it's still controversial. And really, if you pick up 10 articles, I think 5 will say that it works and 5 say that it doesn't work. There's 2 good randomized controlled trials. Lay had 60 patients in his study, with 30 in each arm, and the progression of avascular necrosis was significantly reduced. 1 out of this series of 30 developed subsequent avascular necrosis in the bisphosphonate group, compared to 17 out of 25 in the other group, whereas Chen showed that there was no difference in his group, with a similar time frame of 24 months in his study. And this comes with side effects of using bisphosphonates. As we're aware, the oral form, which is most commonly used, can give patients nausea, upper GI irritation, as well as esophageal perforation and ulceration, whereas this intravenous form, which is not commonly used for this condition as a maintenance, can cause the problems of jaw osteonecrosis. Surgical options, which is really the meat of the topic here, I think can be thought of as either joint preserving or joint sacrificing, and its options include that of core decompression, of bone grafting, which can either be vascular or non-vascular. There are osteotomies that have been described, as well as arthroplasty being the final endpoint for stage 4. Another surgical option that I haven't written there but will mention is arthrodesis, which is an option in the young population with stage 4 avascular necrosis. So core decompression, as I mentioned, this was something that was found incidentally by Fecat and Arlett while they were biopsying femoral heads, that these patients got better after decompression. And the thought process is that it reduces bone marrow pressure and it induces neovascularization of the femoral head. There are multiple techniques that have been described, and these can be combined with a grafting procedure at the same time, either with autologous bone graft or synthetic bone graft. And I think this is generally something that's been accepted in the orthopedic community, and especially locally, that in patients that have pre-collapse, they have good success rates with Farage. The treatment of early stage of avascular necrosis with Farage is well documented, and again, Michael Mont has shown in a recent review that in grade 1 and grade 2 of over 1,000 patients, 70% success rate with them not requiring any further surgery, and over 60% of them had a good radiological outcome. And certainly in the later stages of avascular necrosis, there is less indication for Farage, and in his systematic review here, all stage 3 required further operations, which were predominantly arthroplasty. The core decompression options, there are multiple, and certainly the trend now is to use smaller diameter trephines as opposed to using one large diameter trephine. This is more the first technique that was described, with an entry point above the level of lesser trochanter and a large drill, like a DHS drill, being guided under II into the necrotic segment. But there is high complication rate in particular with this technique, and now I think it's more the trend to use smaller diameter trephines over a guided KY with multiple passes, and this has a lower rate of collapse in the literature with less complications. Something that I've seen a little bit of working at my last adult job at the Austin is to use tantalum implants. Consultants there using that, so doing the farage and putting a tantalum implant up into the subchondral bone to then provide structural support for the femoral head. Although there isn't much evidence for this in the literature, and it's certainly controversial. Bone grafting, as I mentioned, can either be non-vascular or vascularized. Again, there's very poor evidence out there for either of these procedures. But typically, you can use a non-vascularized bone graft when the subchondral collapse is less than 2 millimeters. There's 3 commonly described approaches. Femoster is where a bone graft is passed through the drill tract itself, which is probably the most common technique. Light bulb technique is one where a cortical window is made at the margin of the head and the neck, and then the bone graft is passed up into the femoral head. And lastly, the trapdoor, which is a bit more of a cowboy approach, where a hip is dislocated. There's a window made in the femoral head itself. This is packed with bone graft, and then the window is then closed again with articular surface coverage of the femoral head. Lieberman, who again is a predominant name in avascular necrosis, did quite a few of these trapdoor techniques on a series of, I think, about 80 patients. At almost 5 years, he reports good to excellent results in almost 75% of his patients. Of note in this study, he had poorer results in those with a higher Kerbal angle, so again, that 200 degrees as the critical value, as opposed to the ones that had a Kerbal angle of less than 150 degrees. Vascularized bone graft, this is something that I've not seen during my training, and sounds awfully difficult, and the options that you use either a vascularized fibula or iliac crest, and then to then take the perineal artery and vein anastomosis with ascending branches of the lateral femoral circumflex artery, and there's very poor evidence for this in the literature, certainly no level 1 evidence. It's technically difficult, and there are plenty of complications that have been described from the donor site itself, which is very important, and it requires 2 operative teams and a long anaesthetic for this procedure. William Ewood in CORE looked at this, and he had a retrospective review of patients that were pre-collapse and quoted a survivorship of 3/4 at 10 years, which then degraded to 60% at 15 years. An immune duration in his subset here of 8 years, 8 years to total hip replacement. And he reported at the end of his study he had good pain and function in his far majority of patients with avascular necrosis. But again, I think this is quite a specialised treatment option that if it's done in an experienced centre that does many of these, they may get better results than those that are not doing this as often. Osteotomy, again, it's not certainly not well described. I haven't seen this during my training either, and I think this is certainly less used than vascularized bone grafting. But the options are either that of rotation or angular correction, so valgus or varus osteotomies. And again, this needs preoperative investigation in regard to what area and the amount of area that's affected for planning. And it's certainly used again for those patients that have smaller lesions and smaller Kerbal angles. And in the subset of patients that are young but are fecal anal at 3 or 4, so you're looking for surgical options that are less than arthroplasty. The Japanese have especially good results in the literature, but these are certainly not reproducible in most European and British articles out there, and it makes conversion then to subsequent procedures with almost all these patients end up far more difficult once you've changed the proximal femoral geometry. In terms of prosthetic options, resurfacing is an option which has gone out of favour in our local community, and certainly I'll go through the joint registry, but there hasn't been any in the last 5 years put in for this diagnosis. Hemicap, which I put purely as an option and one that I couldn't find any good literature on, and I certainly would stay away from mentioning that in the exam, and of course then total hip arthroplasty, which is really the gold standard for grade 4 fecal anal avascular necrosis. Looking firstly at total hip replacement, the results are worse when the etiology is avascular necrosis compared to osteoarthritis, with higher rates revision compared to osteoarthritis in the joint registry and internationally, and a higher dislocation rate overall in the literature. The difficulty, of course, with this is that most of our patients that present with this are young. And in the older literature, they had a very high failure rate, which is not being reproduced now in the more current literature, which is good. Looking at the joint registry here, this is last year's joint registry, which is now out to 12 years. The revision rate of osteonecrosis is slightly higher than that of osteoarthritis, but it's certainly less than rheumatoid arthritis and just under hip dysplasia itself, so 9.4 at 12 years. Partial resurfacing, as I said, there's not many of these in the National Joint Registry, nothing in the last 5 years, and a revision rate of 5 years of 22.9%. So I think that's with good reason that that's been ceased. So, to conclude and to summarise what I would do, this is a complicated slide from a current concept review that we read for the exam, but I think can be broken up into whether a patient presents with symptoms or is asymptomatic, whether the patient has radiological changes, which is either collapse or pre-collapse, and finally whether or not they have subchondral collapse that is more or less than 2 millimeters, and finally whether there is changes on the acetabular side. Again, you're guided by Fecat and Arlett stages, which then guide treatment. And so to summarise, as Sasha said, these patients I don't think we see, and certainly don't see in public outpatients who are preclinical and pre-radiological, but they require observation. Stage 1, which is pre-radiological and plain films, but has an abnormal MRI and presents with symptoms, I think requires very close observation. You would consider bisphosphonate use, as well as potentially core decompression, depending on their symptomatology and the amount of femoral head that's involved. Stage 2, which is, I think, the stage that we see most commonly and is important to address, can be treated with both bisphosphonate therapy as well as Farage, and then depending on surgeon preference, whether you do an adjunct with bone grafting, be it vascular or non-vascular bone grafting. Stage 3 and stage 4 are obviously more difficult to treat. I think most of the controversy is those patients that are in stage 3, and especially the younger cohort of patients who present with subchondral collapse already. Certainly Farage has a very high failure rate in isolation in this subset. So an option in the young person who has got minimal subchondral collapse here may still be bone grafting. Certainly in those that have a smaller Kerbal angle and in a centre that does osteotomies, this may be an option. But as mentioned, this makes subsequent conversion to arthroplasty very difficult. Stage 4, I think there's good evidence to show that total hip arthroplasty now is the treatment of choice, and I think that's gold standard for this at stage 4 Fecat and Arlett. Thank you.